to introduce you to Dr. Gelmanova. Dr. Gelmanova holds a medical degree from the Kazakhstan State Medical University and Master's of Public Health degree from Boston University. Since 2001, she has been working with the TIH Partners in Health MDR-TB program in Tomsk, Russia, which was one of the first GLC-approved MDR-TB programs in the world. She has been involved in all aspects of MDR-TB clinical management, but her main focus has been with setting up treatment delivery in rural areas of Siberia and developing programs aimed to improve adherence and final treatment outcomes. From 2004, Dr. Gelmanova has completed her operational work with research projects on MDR-TB treatment and prevention. In addition, Dr. Gelmanova has provided programmatic support for the Global Fund project in Kazakhstan and assistance to Thailand Ministry of Health developing a 5-year MDR-TB plan. Okay, so now I would like to give a floor to Irina.
for quality assured site. So the result might be higher, we don't know. And about a year and a half ago on the conference, IUTLD conference in Lille, there was a presentation about PET study, which collected prospective data from 9 countries. And they showed the preliminary results of acquired resistance during the treatment. And they compared GLC projects, so Green Line committee approved projects, which are supposed to have higher quality, with non-GLC projects. And as you can see, there is a huge difference. Emergence of fluoroquinolone resistance in patients who didn't have it before was 20% in non-GLC projects and only 10 in GLC projects. The most amplification acquired resistance developed in patients who had initial resistance to fluoroquinolones, or second-line injectables to one of them. It's called pre-XDR-TB. So they have either fluoroquinolones or injectable. And in non-GLC project, 51% developed XDR-TB, while only 21 in GLC project. So it shows that actually the way we organize MDR-TB treatment determines outcomes and determines, as you can see, additional resistance during treatment. There is a number of factors published which significantly proved by research influencing treatment outcome. Resistance to ofloxacin, second-line injectables, XDR-TB, prior use of second-line medications, extensive cavitary disease, comorbidities, especially HIV, diabetes, low body mass index, low adherence, alcohol and drug abuse, and some social determinants like migrant, homeless, unemployed. So, and in this lecture, let's try to see what can help to overcome these problems, what actually was published and proved to work. You already had a lecture about effective regimen design, so I wouldn't repeat. I just wanted to start with a slide to emphasize that effective regimen is very important. And the recent data actually suggests, it's not here, but it was in your previous lecture, that if you use about 6 medications for 5-6 medications for XDR-TB, you will improve your treatment results. So there is still possibility to get better results even for XDR-TB. The next one is the need to address TB-HIV co-infection. And several projects were able to reach similar MDR-TB treatment results for HIV-infected and for HIV-negative patients with simultaneous treatment, antiretroviral treatment. And early start of this treatment is recommended during TB treatment, and it showed to improve survival, especially in patients with low CD4 count. And several projects were successful by not just providing HIV treatment, but also integrating TB and HIV care. So when patient would come to the clinic, he wouldn't need to see multiple doctors or making multiple appointments. So he would just come to one provider and he will get treatment. Okay, and another issue which has brought much attention in the recent literature is diabetes in TB patients. And in some settings, diabetes reached 36%. What is currently recommended is initial screening and proper treatment for diabetes. There are some suggestions, but it wasn't proved that prolongation of MDR-TB treatment in diabetics might be beneficial. But I saw only suggestions. I didn't see any proof that it will work. Just for you to consider. The role of surgery. In January this year, the meta-analysis and systematic review of surgical interventions for drug-resistant tuberculosis was published. And the analysis showed that long-term successful outcomes were achieved in 87% of surgical patients. Of course, there is a selection bias, so patients might be some severe patients wouldn't be eligible for surgery. But there was also one interesting study made in Korea where the analyzed patients treated with MDR-TB and XDR-TB treated with surgery and followed just with first-line medications. And the effect, cure, and absence of relapse was reached in 15 out of 19 patients. So that study showed that surgery itself has certain effect on MDR-TB treatment. Now the second quiz, please. What is the most common side effect patients experience during MDR-TB treatment? Is it ototoxicity, gastrointestinal, neurological, electrolyte disturbance, hypothyroidism, or renal insufficiency? Okay, so let's move. So this is the data from uh, five projects located in three different continents: Estonia, Latvia in Europe, and Russia, Europe, Asia, Philippines in Asia, Peru in South America. And side effects were registered in 93% of patients, and gastrointestinal, like nausea and diarrhea, were leading. And in some projects, mild gastritis was actually noticed in 100 patients. It was in Peru. And as you can see, there is a number of other side effects. High ototoxicity, 15%, 16%, hypokalemia, um, uh, peripheral neuropathy, about 9%, psychosis, and 4%. Quite low rate of hepatitis, only 2%. But I would just suggest for in each region to look for your own profile. For example, Lesotho reported the highest hypothyroidism rates, 69 in adults and 79 in children. And they also reported high hypokalemia in children and ototoxicity. On the other hand, Russia, probably due to high alcohol rate of alcohol users among patients, reported high rate of psychosis and hepatotoxicity. So side effects are some of the side effects are life-threatening and if not recognized and treated promptly. Others are not severe but discourage patients to take medications. So there is a strong suggestion, we would call it, to use aggressive management of side effects to prevent patients from default or prevent death. And what are the common problems we see in side effects organization? First of all, poor training of medical staff. Limited resources. Not everyone is testing, doesn't have ability to test, to provide biochemical testing, for example, for potassium. Patients have to pay for side effect medications. And they might be provided with them at the hospital, which is common in post-Soviet republics, but might not be provided in ambulatory settings, especially outside of the main city, because of the different financing structures, mechanism for hospital and outside of the city villages. And I saw also projects where patients were asked to tolerate and wait, and no real help was provided. For example, patients were certainly experiencing some psychotic symptoms, and the nurse just suggested him to tolerate and wait. The nurse didn't know actually what to do in this case. And another problem, DOT workers might not be connected to physicians, and they don't report about side effects. So the key activities, what you should always think about in your project should be the development of standard monitoring guidelines, provide training to everyone, including DOT providers, about MDR-TB side effects and HIV treatment if necessary, improve access to side effect medications, to have them for free to everyone, disregard of their, like, doesn't matter where they're located, even in outreach village. And also you should pay attention to details. You need to think in advance how to bring specimens from outreach areas for testing, how to improve access to specialist consultations. And another suggestion is to use side effects questionnaire. A couple of projects used it. So DOT worker would fill in questionnaire once a week. He would actively ask patient all of the possible side effects, and this questionnaire will be sent to physician. There are several positive sides from this intervention. First of all, some patients might feel uncomfortable speaking about some of the side effects, like diarrhea. And some DOT workers are not so attentive, they might have limited time, and they wouldn't ask actively about everything. And also, this way, by doing this questionnaire, for example, once we can send it to physician, you also improve connection between DOT worker and physician. So it's really good to do. It's recommended to develop a team. So again, DOT provider will be connected to the nurse doctor. Some of the successful projects, they have regular meetings or cell phone discussions. Sometimes DOT workers were provided for free cell phones, and they could call, they would have hotline, and they could call to the nurse or doctor at any time if they needed some help with side effects. And in the project, which treat patients completely in outpatient settings, you should still consider and try to establish the possibility for short-term hospitalization for patients with severe side effects, especially for patients with comorbidities. I provided some possible resources for side effects management. Probably you know most of them, but it's just in case. And there are a number of others, but I just listed 4. You can see them after the lecture if you want. So now let's speak about the role of adherence in MDR-TB treatment. In our project, we recorded each dose of medication taken by the patient, and we did it separately for each medication and for each intake, for the morning intake, for the evening intake, or if it was the third one, we also had the third lunch medication intake registered. So it was kind of detailed information. And then we developed a variable for our analysis, like adherence. So the number of taken doses out of prescribed, and non-adherence, a number of doses not taken out of the prescribed. And here you can see multivariate analysis of risk factors associated with absence of culture per conversion among MDR-TB patients. And actually, not surprisingly, we found that you can see here, the non-adherence has the highest odds ratio. 12, it was higher than the odds ratio for XDR-TB. What does it mean? First of all, 12 is a huge odds ratio. And it means that adherence is very significant for the success of MDR-TB treatment. And it's much more significant than any other factors. So then we started thinking, you know, it's kind of difficult for the patient to take all medications. There should be certain level of adherence or non-adherence where it's still safe and patient will be cured. So we use the same data and separated them by the percentage of doses missed. And as you can see, there is no safe missed doses level. Some patients are okay, even missing more than 10%. But for some, it could be really bad. So as you can see, 20% of those who were taken less than 10% of, who was missing more than 10% of doses, so was taken less than 90%, they didn't convert, as compared to 100 patients converted among those who take all medications. Here is the model of factors affecting adherence. There are lots of them. There are personal factors like knowledge, beliefs, attitudes, addiction, psychiatric disorders. There are social factors, family, community, household support, stigma. There are structural factors like poverty, financial burden, unemployment, homelessness, distances, gender discrimination, and law. And health service factors, which we can influence the most, is the way our care is organized and how we treat patients, how convenient we make it for them, and how good is side effects management. Oh, I don't see the title, but one of them, the study published actually just this month, but appeared slightly late a few months ago, is meta-analysis, systematic review meta-analysis of strategies for reducing treatment default in drug-resistant tuberculosis. And they did meta-analysis of 75 studies, and they found significance for between DOT and default rates. As you can see, those who was under DOT, those projects, they had only 12% of default rate as compared to projects who didn't have any DOT. You can see 26% default rate. This study also revealed, this meta-analysis also revealed that the lowest rate of default was when treatment was treated at home on a mixed facility, as compared, you see 9% here, as compared if he had to come to facility, it was 17%. And as you can see, p-value is significant for both. So DOT doesn't come just, if you just bring DOT and didn't add any interventions, it might not work. So if you started direct observed therapy, you need to improve accessibility to healthcare. So it should be close to the patient, convenient working hours, no waiting lines. Patient wouldn't spend his own money on transportation. The best is treating at home or anywhere the patient wants, as I mentioned before, and hiring volunteers to provide treatment in certain cases. One of the there is also using reminders for appointments and medication intake is helpful. One of the recent research publications from Thailand showed that they were using SMS reminders for appointments. I'm not sure if they used DOT, I think they didn't, but they still have higher cure rates than in the cohort where they didn't use SMS. And also, tracing for patients is essential, and default search. I don't want to speak much about this. I'm trying to get through to show you some examples. But still, nutritional support. Besides helping patients to gain weight, as I remember, low body mass index was a risk factor for failure and death. Nutritional support, food packages especially, they play an important role in improving adherence. We found in our project that daily food packages were the most effective, especially in the cohort of patients with low intellectual ability and alcohol abusers. And so so it was working wonderfully. If it wouldn't be too far, even a drunk patient would work to pick up his food package. It's a food not only for the patient, but also for the family. It's a possibility to exchange this food for some other necessities. Temporary accommodation might be needed for some outreach patients, for homeless patients, and those who might not so much sick to be in the hospital, but not good enough to go back home. Vouchers for material goods, help with legal issues, for example, passport recovery and some other activities. And seldom income generation activities were also used. Counseling and education, it's individual psychological support, group therapy, patient education, with or without family involvement, peer support groups, provision of psychiatric care, regular psychiatric assessment, and substance abuse specialist support. In the same review meta-analysis which I mentioned before, it was found that patient education was statistically significant, had statistically significant effect across the studies. Only 9% default versus 16. I would like to speak a little bit about psychological support group which was organized in Peru for MDR-TB patients. Peruvian project is one of the first, actually the first one, where the attempt to treat complicated drug-resistant tuberculosis was made in the very poor country. And when they started treatment, they found that the majority of patients had depression, anxiety, so some pre-existing conditions, and no wonder in many of them lost their relatives. Actually, the first psychological support group, which was organized, had only 20 patients, and 10 of them experienced death of an average 2 relatives. Many patients experience depression because they were told by other treatment providers that there is no hope for them. So, and also in this cohort there was a high rate of additional side effects, depression and anxiety developed while patients were in treatment. So first, one group was organized in Peru, and then 7 additional appeared in Lima and other provinces of Peru. Patients would refer to the psychological support group after they would have 2 negative cultures, and if they would experience some depression or anxiety symptoms, if they were speaking about possibility of suicide, if they would speaking about possible default, if they would have some family problems. The meetings were bi-monthly, and in addition, they would have recreational excursions, symbolical celebrations, birthdays, and periodical family workshops. And they would call themselves like a family, and the default rate was amazingly low, 3.5%. And this study actually resulted in a number of publications. I'm citing here only one, but they also developed a manual how to organize and how to proceed with this group. It was done by Partners in Health, and I know it was in Spanish. I'm not sure it was translated, honestly. But there is another publication and chapter in the book, if you are interested, I can provide later, where also more detailed information is given than in the article provided here. Down. You also need to look at your vulnerable populations. They are specific to each region. For example, migrants. If you have migrants, bilingual translators, bilingual questionnaires, and other material. So the same meta analysis, which I mentioned before, also find out that actually individual interventions were not so much successful, but a package of financial support, nutrition, transport, and reimbursements was associated with a low default rate. So, in conclusion, combination of interventions is recommended. And as we remember, adherence is influenced by a number of different factors. So, if you really want to improve your adherence in your cohort, you should think about combination of interventions. Let's look at the quiz 3. Which intervention is less likely to improve MDR-TB treatment outcome? Reimbursing patients for transportation costs to the health facility. Second, setting up home treatment observed by community health worker. The third, prolonging hospitalization. Improving staff motivation and supervision, the next one. Then providing free auxiliary drugs for side effects management to all patients. Improving access to surgical treatment. Okay, so let's look at the next examples and we will see the answer. I took few recent publications which shows actually the complex interventions and how it worked. Taiwan, they had MDR-TB treatment from 90s, and it was mostly government organized, and treatment was provided mostly at the hospital, private hospitals, but it was reimbursed by insurance, so it was free to patients. And patients would attend outpatient clinic afterwards. Public health nurses had no training in management of adverse effects of MDR-TB treatment. Despite of twice a day medications intake, DOT was provided only once a day. So one of the doses was unsupervised. And incentives and enablers were the same for MDR-TB patients and DOTS patients. the cure result was 61%. So then on the country level, they decided to change the system, and it was hospital-initiated treatment. They organized 5 professional teams for treating of patients, and these teams um, and, and a patient-centered home-based treatment was designed by, which was provided by DOT observers and nurses. Everyone was trained. There was a better system of reporting and managing side effects. So, and it was a real team, so they were connected. DOT providers and nurses and physicians were all connected. And there was much more flexibility regarding incentives and enablers. So, and this complex approach resulted in cure result of 82%. So the next study was done in South Africa. It was also published recently, last year. It was done in KwaZulu-Natal, which is known for high HIV rates and for poverty. Usually in South Africa, the common treatment is centralized treatment, and patients require long hospitalization. But because of the number of patients, there are long waiting time to get to the hospital, up to 120 days, while patients are deteriorating. So as you can see, I'm speaking about centralized treatment, what existed and still exists. And patients had to go long distances after they discharged to get to the referral hospital. And they have to go to different providers at different times to be seen for TB and HIV. And as soon as they discharge from the hospital, no adverse effect monitoring and adherence support is provided during continuation phase, and no involvement of family members in the patient care. So, and in one of the regions, of this province, they decided to change it and try decentralized treatment. Very short initial hospitalization, but not always. Satellite MDR-TB clinics closer to patient home. And as soon as patient is at home, let me move. A nurse with a driver would come to do injections. And after intensive phase, community health worker would continue DOT. So MDR-TB and HIV were integrated, so patient wouldn't need to do several visits now to see for both diseases. And family members were identified and trained to serve as treatment supporters. So it was in Tugela Ferry district of KwaZulu-Natal, and out of 80 patients who started treatment, 66, so meaning 83% were HIV co-infected. So it's very high HIV co-infection. And culture conversion among patients who finished intensive phase by the time of publication was 100%. And preliminary outcomes were 77% were either cured or still on treatment, 82% had undetectable viral load. Few patients have required escalation of care and severe side effects or died. So as you can see, with the certain complex of interventions, you can reach high cure result even in HIV co-infected population. And another program was designed, it's in our setting, Sputnik program. It's also home-based, but a selection of patients, selectively, patients were referred to this program. It was quite a small program, so only those who either missed few weeks of treatment and completely refused to continue treatment, or disappeared, or was missing more than 25 of the doses were referred to the program. They could be treated anywhere besides home. If patient wants to be in a car, it could be possible. Next to the market, it's possible. And strong social support, psychological and psychiatrist consultations. And patients with addiction were offered detoxification with limited options for further addiction treatment. It was mixed population of patients. We thought that both acceptable and MDR-TB cases should be treated properly. But 72% of patients were MDR-TB, and 86% of them were having chronic alcoholism. 32% were drug users. 36% had default in the past, and 36% were ex-prisoners. And hepatitis B and C was on 40%. So here are the key results. 68% of MDR-TB patients were cured. So our program also illustrated that even in very socially very difficult population of patients, which is considered by health providers, if you provide a certain complex of interventions, you can treat the majority of patients successfully. The last point I wanted to make to the healthcare improvement. You need to think about adequate staff reimbursement and rewards, intensive staff education. You need to give everything to your staff to do their job properly. Like Sputnik, they have a car, they have limited workload, they have strong administrative support. We had meetings with them every week, and if patients needs to be referred to certain place, for example, for treatment of alcoholism later, if patient agreed, usually the administration would help to arrange it. And you need to think about very strong system of supervision. Several studies on DOTS have shown that intensive supervision of staff alone contributes to improved treatment results. And but you need to have enough staff, transportation, and enough visits. And I think my time is almost over. So I'll just move to the next. Here is a summary, which I was speaking about, what actually helps to improve treatment outcomes. But when you're thinking about your region, you shouldn't just take someone's example and implement exactly the way it was made. First, you need to look at your major obstacle in your treatment. Think what are the underlying problems, and for each problem, what is the motivation or key factor which can change it. And you need to think about possible solution and choose the right one, and then try to implement, pilot, and evaluate. And thank you. Okay. So I see. Okay, so what is the main reason for low cure rates? Is severe disease or poor adherence? I think it's a combination, but we actually seen patients with very severe disease, which were improved substantially with good adherence. So I would think that adherence is more important. But of course, there are certain cases where you cannot do, which will be difficult to reach cure. But in majority, I think pure adherences might be more important. What to do if no side effect medications is available in the program? You have to think about this, because without side effects, again, patient wouldn't continue to take all medications. So, and you will stop, you will discontinue medications. And if you discontinue medications, you don't have an effective treatment. So you will have higher failure rates. So you need to think about the, like, you can get it from other projects, a certain list of essential side effects medications. Try to choose maybe cheaper ones, or, and but you need to have them. Otherwise, I can't imagine MDR-TB treatment without this. How to organize surgery in the peripheral locations of the country where no surgeons are available. Actually, it's better to have a tertiary hospital where you can refer these patients, and you have better quality, better outcomes of the surgery. You can organize proper surgery in each district, and it requires certain equipment and certain experience. But you need to get agreement, and you need to set up the system of consultations to make it possible to refer and transfer on time patients from outreach areas to the surgery, and as soon as possible. Really, as soon as you identify someone with extensive, for example, resistance, you need to think about surgery. What routine exam can we do to follow up of MDR-TB patients and when? Are there any incentives for surgical intervention in the project design? Routine exam, you mean to monitor the treatment you do? People would recommend to do culture, and it was a study published. Some projects still use smear, and the frequency is discussed, but at least once in 3 months. But there is a certain set of biochemical tests which you need to do. It's potassium, it's liver, like transaminase, bilirubin, it's also creatinine. But, you know, it will be the whole additional lecture. What I would recommend you to look back to those slides where I showed some resources and go to those links and read chapters about side effects. You'll find much more. And for surgical intervention, we didn't have any incentives. So, and I didn't hear actually if someone was using. I think the best incentive a patient knows that he will be cured. Do you think that active involvement of community pharmacists in DRT will improve adherence, early identification, management of side effects, and adverse effect? I mean, to provide DRT, I mean, if you have pharmacists who could agree to provide DRT, it would be great, but it will improve. And I think several projects used them, and also for early identification. But you need to train them, you need to provide them support, and you need to supervise them. Most of the successful projects, again, I would repeat, they had good supervision. Otherwise, you wouldn't have good direct observed therapy, and you wouldn't have good treatment outcomes. So I don't know if I answered enough. So yes, it will improve. How was adherence assessed in multivariant analysis? How we will look, there was a measure, a number of medication missed out of prescribed. It was non-adherence. And we looked at adherence from the day the patient started treatment until culture conversion, or if he never had culture conversion, until the end of treatment. So we had summary because we had very detailed data. We could calculate this ratio. And alternatively, we also tried to look at adherence in the first 6 months of treatment. And basically, the results were the same. Adherence was the leading risk factor for, at least in our settings, for absence of culture conversion. Okay, next I'll go. How far should we go in providing information to drug-resistant TB patients? If we say the percentage of treatment success is 54%, they may decide not to start the treatment. If we avoid telling them this, we are hiding the truth, and the patient is not really giving informed consent. I would provide them the truth. I would say this is the average, but if you will take all medications, you will have high results. You will have 69, or some project actually showing close to 80. So you saw Taiwan data. So this might be a good start to speak them about adherence and about but telling them that the road to the success will be quite difficult because they will get a number of side effects. And in this case, yeah, so I think it would be useful. I don't know your settings. I think in our settings, mostly patients actually don't think much about this. They're not getting scared, but okay. The next one, is it feasible to use the mHealth approach for reminders to take pills? You know, there's a number of electronic devices which remind us which I used, but I found that if treatment doesn't have much side effects, it might be the best approach. I'm not sure. I think it just reminder, so you open the pill and it's recorded. There is a number of them. But we visited a number of patients, and patients try to hide the truth. They try to throw their pills if they are not supervised because of the high rate of side effects. Even they don't have severe side effects, they say, I'm capable to do something at home only for 2-3 hours a day. I don't want to live like this. So there are certain ways to use electronic devices actually to improve supervision, but it's mostly used to see, I think Pakistan is using mobile phone to track if nurse come to the patient, and it has GPS. And I think India used computer for those patients. So if patients come to the clinic, he used fingerprints to confirm that he came to the clinic, but it's mostly for supervision. I still believe that real DOT is needed. It's better than just reminders. Food packages are the incentives for patients or support. They're both. Patient eat well and recover, or have high chance to recover, and the incentives because like the way we use, if you're adherent, you get them. So I think it's both of them. But we found that with monthly food packages, we also have a dilemma when the time comes to report about adherence, and those who were adherent would get packages, doctors try to hide this information because they felt pity for their patients. So, but again, it's a good way to improve nutrition. It's also gives some incentives. What should be in the food package actually was provided. The review, there's a nice slide. If you look at the previous lecture about community health workers, they tell you what should be included in this food package. How can we improve our cure rate in Rwanda? It's at 58% now, determined at 5 negative cultures in the last 12 months. I can't say. You need to look what is the problem, because each project has its own problems. Maybe you don't provide HIV treatment. If you do provide, do patients take it? Is it directly observed? If you have DOT, are the DOT workers supervised? Do you have side effects management? So you need to get through and see what are the elements are missing. The best would be a way probably to have someone with a supervisor visit and look exactly to speak to patients what's actually done different. So I can't tell you without seeing the program. I'm sorry. The next one, DOT by responsible trained family member is the best for MDR-TB. I don't believe that family member is a good DOT provider, but for example, in one of the projects I was speaking, family member was trained and he was used. I think with a really good administrative support, training, supervision, it might even work. Sometimes, yeah. But I saw a number of cases. But I actually saw a number of cases where a family member, for example, even a nurse, wouldn't give medications to a patient. We would come to visit them, and the patient, we would ask her how her husband takes medications. She would just refer to him. There's always something going on in the family. So I think preferable someone from outside. But some projects use family members. For me, it's more like self-intake. Okay, last researchers are showing that the difference in treatment results on DOT and self-observed treatment is statistically insignificant. Do you agree with this? I don't know which last researchers. I showed you the research meta-analysis for drug-resistant TB. There are some reviews made by Volmic and Cochrane data, Cochrane research, when they showed that DOT didn't matter, but it was first of all done for DOTs. And I would say adherence for DOTs is not as important as for MDR-TB, and because the medications are stronger. And also, I would say that sometimes there is no real DOT even if it's reported. So one of the research actually looked, I don't remember, it was done in Asia, I don't remember where, it was for dots. They interviewed patients after they finished treatment, which were considered to be on DRT, if they had DRT or not. And a number of them said they didn't have, and those who didn't have actually had worse results. So there wasn't, if it would be real DRT with good supervision, and then you can continue. And also another problem with those published reports, some of them were from South Africa. It actually was a while ago. It's not recent, but DRT was provided at far in far locations, so the patient had to go several kilometers to get treatment. So DRT should come in a complex with other interventions which help patient to adhere at home with social support and etc. Then it works. Just DRT will not work. I agree. Okay, thank you. No more questions, and thank you for your attention. Please send some questions if you have them, and good luck with your work. Bye.
Thank you, Irina. This brings our sixth and final talk to an end. I would like to sincerely thank Irina Gelmanova for a very informative and interesting webinar. And I would like to thank you all for your participation.